But there's a second point in addition to the population dynamic, which is very clear. And that is that if poor families don't have their own individual demographic transition to lower fertility rates, when you have impoverished families trying to raise 6 or 7 or 8 children, as is the case in so many of the least developed countries of the world, the result is quite obvious. You get investment maybe partially in 1 or 2 of the children, maybe an eldest son. But on average, the children do not get the kind of investment in education, parental time, nutrition, access to health services that they require to grow up as productive as they need to be for successful economic development. So the reduction of high fertility rates to low fertility rates as part of the demographic transition has fundamental importance in 2 senses. One is to limit finally population growth, and the second is to enable parents to invest as they need to invest in the so-called human capital of their children. That means, in less jargony terms, in the health, in the nutrition, and in the education of the children. And if poor families are trying to do that for 6 or 7 children, they simply absolutely can't do it, no matter what the state is or isn't providing. And typically the state isn't providing, of course, in these least developed countries. So the success of the demographic transition is fundamental. And since so much of our project is about Africa, where the epicenter of the global development challenge lies, I want to stress how the sexual and reproductive health services are fundamentally important for Africa to break out of the current poverty trap. Of course, on the mortality side, we still see the highest mortality rates in the world, often under 5 mortality rates of 200 per 1,000 live births, essentially the only place in the world, with the exception of Iraq and Afghanistan, where that remains the case today, are the still many countries in Africa with this shockingly high under 5 mortality rates. But the fertility rates also remain startlingly high. Often in rural areas, the total fertility rates are 6 or 7. I was just in 2 impoverished communities last week, one in Kaduna province, Nigeria, and the other in the Tabora region of Tanzania, just as poor as can be imagined. No access to health care at all, including sexual and reproductive health services, but even rudimentary health care for infectious disease control, for medicine in the event of malaria, massive deaths, but also massively high birth rates. And as everybody knows in this field, the fertility rates far outpace the mortality rates. The mortality may be 1/5 of the children not surviving to their 5th birthday. But with a fertility rate of 6 or 7, that means, say, 4 or 5 children surviving out of the 6 or 7 who are born. And that means that each mother is, in fact, raising 2 or 3 daughters, if not more, who will survive to adulthood. And that means a population that doubles or faster every generation. It's quite clear in this context, and this is why I belabored the point, that Africa needs a demographic transition right now. And what I'm finding is that in policy terms, this is being discussed for the first time that I've heard in the many, many years that I've been working with African governments. Population is becoming front and center in Senegal and Ghana and Ethiopia, in other places, because the need for a voluntary-based demographic transition is really coming to the fore, both on reducing the mortality and also on reducing the total fertility rates. This report makes clear what's required for that. The first thing for demographic transition is child survival, because if the children are not surviving predictably, the parents will not choose to voluntarily reduce fertility rates. So child survival, in my view, is front and center. Second is empowerment of women. Literacy for girls, at least secondary education for girls, empowerment of mothers to make choices. Third is availability of health care, and especially availability of family planning, contraception, and other aspects of sexual and reproductive health care, as Stan Bernstein and his team so ably have documented. And of course, a fourth element of this is higher productivity in livelihoods in rural areas. Because as farm yields rise, as off-farm economic activities improve, the opportunity cost of women's time rises. The choice of having fewer children and investing more per child then becomes an economic imperative as well. All of this is to say that the demographic transition is part and parcel of successful escape from extreme poverty in any poor part of the world. It's particularly urgent in Africa. The elements of it are completely in line with ICPD and especially as stressed by this report. This is voluntary. It comes through empowerment and choice, not through mandate. It comes through access to essential health services. It puts child survival and investment in children, especially in the girls who lack that investment, front and center. It requires strategies for outreach, as Dr. Keneal has been working on, strategies for community health workers who go to the households to make clear what the options are, because this has been shown to help bring about a demographic transition even within a decade, as well as to lead to dramatic reductions of child mortality rates in a short period of time by introducing impoverished households to the health system, even in places where women are often excluded from services unless there's an outreach, not just a waiting for those women to come to the health services. In any event, I think I've gone on way too long. It just is to say how the agenda that is being launched today, it's not being launched today, how the report that's being launched today, explaining again the agenda which has been in the air for so long, is so central to everything we're trying to accomplish in reducing, ending extreme poverty, hunger, disease, inequalities faced by girls and women, and environmental degradation. All of this is on today's agenda. Let me conclude where I started. I want to congratulate Nils for giving us the venue to launch this and for making global health such a core part of the public's understanding through what the Global Health Council does, and to congratulate Stan Bernstein for a fabulous report, and all of your team, Stan. Thank you so much.
Thank you, Jeff. I know you're ready. Okay, our next speaker will be Anna Langer, who's the president for the past year and CEO of Engender Health, which is an institution based in New York City working globally on reproductive health services. Dr. Langer is a physician with board certification in pediatrics and neonatology, as well as a reproductive health specialist and a public health researcher. She has distinguished herself as a worldwide leader in the application of research findings to influence policy and clinical norms in the arena of reproductive health, women's health, and family health and services. She's worked over the past 20 years in this arena in Latin America and globally. Before coming to Engender Health, spent 11 years as the Population Council's regional director for Latin America and the Caribbean. And as you'll hear from her accent, she's originally a native of Buenos Aires, Argentina, and has spent the last decade before moving to New York in Mexico.
Thank you.